to receive treatment today.
I'm sorry, what?
They're supposed to be coming in right now to get treatment.
Good afternoon, everyone. My name is Dr. Nezami, and I am the CEO and President of Sahel Oncology Research Cancer Institutes of America, Orange Coast Medical Center of Hope. We pretty much are going to explore the scientific merits of application of epigenetic therapies, specifically in a protocol called multi-targeted epigenetic therapies, or MTET, in patients with glioblastoma, and discuss the rationale on using epigenetic therapies specifically in a customized fashion to target glioblastoma stem cells and reversing radio resistance. Precision oncology challenges, as you know, first of all, is that it's a molecular targeted approach, and it requires to have molecular understanding and molecular profiling of the tumor before we can identify what are the targets, if they're actionable or not, and then use therapies that modify the gene expression, which is defined by any sort of epigenetic therapy. And in order to do that, we use liquid biopsy, which looks at a signature of the tumor. These liquid biopsies generally are obtained from the serum or blood, at times from the CSF. The technologies that used to be used were DNA microarrays since I started doing this back in 10 years ago. And as you know, it has evolved to PCR and next generation sequencing. So now we can get more than 592 gene expressions just by doing a simple test and identify what are the driver genes and passenger genes that unfortunately in the standard of care, most of them are still non-actionable. The reality is that the more we have actionable targets, the more we have a chance of stopping these genes from being active. But that said, all of these targets are tumor daughter cell targets, and none of them are stem cell targets. And for me, it was always a challenge on how we can find a protocol that targets the cancer stem cell targets and be able to modify the response to any sort of conventional treatment, if it's chemotherapy or radiation, to improve patients' overall survival. So that is basically what we are going to discuss today on how we can basically address this challenge. So the dichotomy of care, as we all know, is that the standard of care is still not as targeted as it's supposed to be. For example, in the case of glioblastoma, standard of care is not doing next generation sequencing or molecular profiling of the tumor or the liquid biopsy. Rather, it's just testing a couple of targets in the pathology, including IDH, 1, 2. At times, we also check the EGFR, and more commonly, we check the MGMT status. But the precision oncology, they basically, it has to be looking at all targets and then find the most relevant treatments that can address the problem. In this presentation, I'm going to discuss that more in detail. So targets in glioblastoma are tumor genomics, epigenetic targets, and microenvironmental or stroma targets, and then stem cell targets. These are the targets that I personally am interested to obtain information. So if we have, beyond the genomics of the tumor, if we have epigenetic targets, then now we have the capacity and the science to be able to target these epigenetic markers. And also the stromal targets that has to do with the crosstalk between the tumor and the brain, normal tissue or parenchyma, that has to do with transcriptional factors and growth factors. And finally, stem cell targets and how we can address those. Survival in patients with glioblastoma is target dependent, meaning that if we can inhibit the tumor targets that correlate with the patient's tumor recurrence and dissemination, then we have the most likelihood of beating the survival. As you know, glioblastoma tumor cells are able to migrate very quickly. And when I refer to tumor dissemination, that's what I mean, that from one side of the brain for one area, it can easily disseminate to the other area just by migrating. So where is the tumor resistant originated? You know, the standard of care of chemo and radiation has not changed since decades ago. And in fact, the first line of treatment has not changed since 2004 or 5, which is still temozolomide. And as you know, both radiation and chemotherapy cause resistance, and they have a cross resistance or cross reactivation model, meaning that if you use chemotherapy, it makes the tumor resistant to radiation. And if you use radiation, you make the tumor resistant to chemotherapy. And yet it is a combination therapy that is recommended to the patient. So patient receives both with the old thought that there is a synergistic effect between the two, where the reality is that there is a cross resistance that happens. So for example, what we have found is that alkylating agents, temodar, which is the first line of treatment used for glioblastoma, increases the hypoxia-inducible factor 1, stimulates the activation of stem cells and making these cells resistant to chemotherapy, to radiation, to radiotherapy. And the same also applies to radiation. When you use any sort of radiation techniques, you make these cells also resistant to chemotherapy. So this is probably one of the most important slides because it talks about epidermal mesenchymal transition and how by using radiation, you can increase this migration of the cells from one area to the other one. In other words, you create an accumulation of beta-catenin in irradiated glioma cells, and these cells have activation of Wnt pathway, where you have this sort of phenomenon that EMT or epidermal mesenchymal transition becomes activated by using radiation. This is not only for glioblastoma, but rather for all type of solid tumors. When you have the activation of Notch1 pathway down to Wnt and snail and slug, which we will talk a little bit later about, you see that EMT increases. And you really have to be able to detect by using microRNAs. Here we talked a little bit about that, and then reverse this process. So hypoxic environment in the brain obviously activates the glioblastoma cell migration. So we refer to the existing literature on using different glioblastoma cell lines, and we had detected a migration in our own laboratory and studies that we have done in our laboratory. We have found a significant reduction of the migration in different glioblastoma cell lines using epigenetic therapies. And so here, again, it refers to the crosstalk between the microenvironment and the oxygen concentration on the microenvironment and the activation of the VEGF and CD133, which correlate with hypoxia. So the more hypoxic the brain parenchyma it is, the microenvironment it is, the more activation of the stem cell markers and the more activation of vascular endothelial growth factor. So there's a crosstalk between the brain microenvironment and the glioblastoma cell line, which defines how much the tumor is going to be resistant to radiation. Stem cell activation and radio resistance. So again, there is a parallel activation of both. So when you have the tumor that is more radio resistant, the same tumor is more active as far as its stem cell markers. So SOX2, BMI, and CD44 expression has been correlated with stem cell phenotypes and more aggressive tumor cells and poor survival. And again, the signature that we have seen is that epidermal mesenchymal transition or mesenchymal cell manifestation is active in this sort of situation. So what we like to do is that we like to suppress what has correlated with this sort of markers. So what do? We go after these sort of so-called non-actionable targets in the standard world and actionable targets in our world when we use in epigenetic therapies. And these include NF-kappa B, as we talk about it here, and many others as we move forward to the next slides. So the role of microenvironment, we talked a little bit about this, and also what we saw as a conclusion, that the key targets of radio resistance. So the pathway that I just explained to you, which is NF-kappa B, PI3K pathway, EGFR, Notch1, snail slug, Wnt, and HIFA alpha. These are all pathways that are interconnected. So in other words, when you have the daughter cells that are active by transcriptional factors, meaning that you have either EGFR or FGF or VEGF, all these growth factors being active, then you will obviously have the downstream activation of the AKT, mTOR, and whatnot. And if you have the Notch1 pathway that is active, then you get the Wnt and snail and slug, and finally EMT. But these two pathways, which one commits to clonal plasticity and radioresistance, and the other one which basically describes the stem cell activity, these are completely interconnected. For example, phosphoinositol 3 kinase, which is a very common activating mutation in all solid tumors, about 40%, for example, in breast cancer and the type of cancer, is also very important in glioblastoma. As you know, there is no commercially available drug that targets PI3K with minimum toxicity. There are drugs like Piqray that was approved recently for breast cancer, but the reality is that in glioblastoma, there is no drug that is approved to block the PI3K and therefore reducing the activation of NK B. That said, there are so many other therapies that you can use, epigenetic therapies mainly, that you can target PI3K very effectively with almost no toxicity. And these are part of the MTED protocol that we use in our clinic. So that is one. The other one is obviously the transcriptional factors and growth factors. So EGFR confers to radiation resistance. So is it checked? Well, sometimes it's checked in the pathology. It is always checked in the liquid biopsy. So if you have a person with glioblastoma and there is leaking blood-brain barrier, so you can see circulating tumor cells in a peripheral blood, then you can actually test these circulating tumor cells for mRNA expression of the EGFR, and that basically is equivalent to radiation resistance. So as you can see here, there are some literature about the presence of these EGFR mutations that is usually seen in older individuals. And also we talk about the angiogenic switch that generally the tumors that have more blood vessels, obviously they have more growth factors involved with that process, including FGFR and EGFR, because these growth factors are all interconnected with the production of the circulating tumor cells and the EMT process. So there are some advances in EGFR targeted therapies. For example, there's a vaccine that blocks the EGFR, and CAR T treatments obviously are there, and obviously epigenetic therapies, which is mostly the focus of our discussion here. So role of epigenetic therapies in EGFR response. Number one is that the combination of histone deacetylase inhibitors and demethylators, as Stephen Bailyn had shown in Johns Hopkins, back in 2015, we saw the significance of combination therapies in a wide range of drugs used in combination to target these two. And this sort of changes that happens in chromatin remodeling can significantly reduce the expression of the EGFR. This is also consistent with what happens with FGFR. And therefore, we are very pleased to have a protocol that shows inhibition of FGFR, EGFR, and VEGF in combination by blocking simultaneously the HDAC and DNA methyltransferase. So what are the other targets? So we talked a little bit about the Notch1 pathway, Wnt, and snail and slug. And then we talk a little bit about transcription factors. But what about stem cell targets? So stem cell targets such as hedgehog is also inhibited by epigenetic therapies. And there is a significant interest in blocking hedgehog target, not only in glioblastoma, but also in other types of cancers such as lymphomas. I personally use hedgehog inhibitors, not in the form of drugs, but in the form of natural compounds that have been discovered as a form of teratogens in a form of homeopathic drugs in patients who have activation of this target. And I have seen some good results there. The future belongs to compounds that have the capacity to reverse the stem cell activation in all types of cancer, glioblastoma specifically. So what sort of molecular targets are we looking at? So circulating tumor cells can be assessed. And unfortunately, in the US, there are very limitations as far as being able to assess circulating tumor cells. There are only a couple of them that have been approved. There's some labs that are doing some studies on getting them out and commercially available. But at this time, we're using Biofocus in Germany, and we have assisted them to be able to specifically target the NMT and HDAC and CTC, and also measure mRNA expression, and also be able to track these patients on their response on the CTC by using MTET. So that is something that we have done. Also, the CTC can be, as I said, measured for the EGFR, and then we can selectively target these and look at response in a matter of 2 or 3 weeks of treatment without any toxicity. So right now, we are seeing patients with glioblastoma, and both early diagnosis or refractory. Our FDA application is for refractory patients. We are treating patients at also a different trial in phase 2 using epigenetic therapies and compassionate studies. And so we are also collaborating with scientists who are involved with the proof of concept studies, and we also are doing studies in relation with synergistic effect with radiation in the form of leading edge gamma knife. And so this is where we are, and we're still open to collaboration, and we hope that in the future we can have more data collected from the patients studied and treated. For any further questions, I'll be happy to address your questions either through direct contacts, or if you're interested, you can study our website at www.allcancercare.com. Thank you very much.